Good morning, everybody. It's great to be here today. Our presentation today is a question of faith and equity, making mental health care work across multicultural communities. And I'm really pleased to be here with Rawle Andrews, the Executive Director of the APA Foundation, and Reverend Dr. Q English, the Director of the HHS Center for Faith-Based and Neighborhood Partnerships. I'm Amy Porfiri. I'm the Managing Director of the APA Foundation, and I lead the Foundation's Mental Health and Mental Health and Faith Community Partnership, which is one of the programs, community-based programs of the Foundation, where we're really trying to build better linkages between our members, psychiatrists, and other mental health professionals to faith communities and vice versa. Just before I introduce Rawle and Dr. Q English, we know that faith leaders play a critical role in increasing access to mental health care. They're often, ones that have the strongest connections with communities. They're among the first people that are contacted by families and individuals experiencing mental health crises. We also know that our faith leaders are getting burnt out. They've been under extreme pressure during COVID and really bear a lot of the brunt of mental health within their congregations, but also within themselves as well. So this session is going to outline the need to form better partnerships with faith leaders and mental health providers, and how by working together we can build better bridges to care for both congregations and faith leaders. I want to just sort of set the stage a little bit before we start here. Oops, my mouse is not working here. There we go. And this really just sort of defines, we're all shared this slide today at the plenary, but it really, it defines the need for change. 50% of the people are experiencing mental health issue, but 44% of the people believe that mental health care is effective too. And 60% are getting into feel that getting to see a mental health professional is not straightforward. More and more people are sort of noticing, recognizing the importance of taking care of their mental health, but really there's such a challenge in making that first step for mental health care. So really what we're trying to do in our work, especially through this Mental Health Works campaign, is really show the need to make mental health care more accessible, more relatable, and easier to understand. This slide we found was so interesting. One of our members shared this with us recently at a conference, and it was the view of spirituality in the treatment of addiction. This was they had surveyed some medical students, but also patients. And what we see here is among the medical staff, they're putting spirituality and religion really low on the list of things that they bring to the forefront in the treatment process. Whereas on the patient side, you're seeing that spirituality, belief in God, is number 2. So what we really feel like we need to do, especially among our members in the American Psychiatric Association, is have them have a better understanding of how faith can be really a supportive component, and know how to talk about faith with their patients. If a psychiatrist doesn't see faith as an asset, it could be left out of that treatment discussion to the detriment of patients and family caregivers. And if a faith leader doesn't recognize that a community member needs additional mental health supports, this gap could also be to the detriment of congregants and family caregivers. So it's really critical that our faith providers and faith leaders see each other in partnership in healing, and not as competitors with each other for the mind, body, soul of neighborhoods. This was really brought to our attention recently at some of the conferences that we've done, is this issue of pastoral burnout. There's 24 42% of faith leaders have considered leaving full-time ministry. That's really astounding. That's up from 29%, which I think was just the last time that Barna did this survey in the beginning of 2021. So that's a really short time period. And we know, we need our faith leaders at the front lines. We don't have enough mental health providers. We certainly know we don't have enough psychiatrists to support everybody that needs the support. So we really need to work in community and really address this issue of pastoral burnout and support our faith leaders. And that's really what our discussion today is going to be about, and really highlight the work that Reverend Dr. Q English is doing at DHHS Center for Faith-Based and Community Partnerships, and that we're trying to do here in the foundation. So we're really just going to have a conversation today. We're not going to do much more presentation. We'll have a few more slides, but let me start by just introducing our leaders here on the stage. Reverend Dr. Q English serves as the director of the Center for Faith-Based and Neighborhood Partnerships at the U.S. Department of Health and Human Services. She works closely with the White House Office of Faith-Based and Neighborhood Partnerships. And the center's core focus areas include addressing COVID-19, maternal health, mental health of youth, suicide prevention, substance use disorder, and working with operating divisions housed within HHS, like the Center for Disease and Prevention Control, SAMHSA, and AFC. Dr. English and her center has addressed the priorities identified by the Biden-Harris administration. She came to us from the HHS state of New York, where she served as deputy director of faith-based initiatives for the government's Office of Faith and Community Development Services. She's the founder and past president of Not on My Watch, an organization that was formed to combat human trafficking. In 2022, she was featured in the state and the city as one of the top 100 most influential religious leaders in the state of New York. In 2015, she was named one of 25 most influential women in the Bronx, and she was awarded the Sojourner Truth Award and the Height Legacy Award by the National Council of Negro Women. These awards, really highlight Dr. English's wealth of knowledge that she brings into her current role at HHS. So we're really thrilled to have her here today. Rawle Andrews is the executive director of the APA Foundation since September 2021, and before joining the foundation, he served for 15 years with AARP National Management Team, and prior to that, he was in private legal practice. Rawle's the 135th president of the Bar Association of the District of Columbia, and he's a board member of the Thurgood Marshall Center and Trust. I could go on and on with the achievements of these amazing people, but I did want to point out that Rawle received the 2023 U.S. President's Lifetime Achievement Award through the Biden administration, and just really the list of accolades go on and on. But I want to sort of start. I'm going to join our guests at the table today, and we'll really just get a conversation started, and we'll leave some time for questions at the end.
Thank you.
Okay. Thank you.
You're welcome.
Reverend Dr. Q English, can you just tell us about the mission and vision of the HHS Partnership Center and the role you play in building bridges between faith communities and mental health supports?
Yes, and thank you. Again, I'm honored to be here. I was with you last night and equally honored to be with you here today. So I want you to think of our center as the liaison between the faith-based and community-based organizations and government. And so particularly when you think of health and human services, you think of maternal health, you think of HIV/AIDS, you think of substance use disorder, overdose prevention. You also think of maternal health. You think of the ongoing work around vaccinations. You think of all the work that you're doing on the ground in this health space, diabetes, et cetera. And so what we do, we serve as the connector, the liaison between you and government, connecting you to resources, to information, to also brainstorming ideas on how you can elevate the projects that you're working on in your communities. What are existing models out there that's working, particularly in this mental health space? What are the models that exist that you can replicate? Or perhaps there are models that you are doing that can be scaled. And so we are sort of that brainchild, from the faith-based perspective. A couple of things I want to highlight, and allow me to reference this, as the Biden administration is committed to addressing, as you know, mental health, and he's definitely leading on this issue. On the one-year anniversary of the launch of the 988 Lifeline, who knows what 988, please? Okay, some people do not know about 988. Okay, so when you think of 988, it is the new 3-digit code for the suicide prevention lifeline, also mental health services. It's an easy code you can call, you can text, you can create a chat, and it's anonymous. 24/7, you don't have to disclose your immigration status, highly confidential, and we are encouraging everyone around our nation to take advantage of that. So on the one-year anniversary of the launch of the 988 Lifeline, Health and Human Services announced that the Lifeline had answered nearly 5 million contacts in the past year, 2 million more than the previous 12 months, following a $1 billion Biden-Harris administration investment. And most recently, President announced new actions that would improve and strengthen mental health parity requirements and ensure that more than 150 million Americans with private health insurance can better access mental health benefits under their insurance plan. The administration's proposed rule reinforces the law's fundamental goal of ensuring that families have the same access to mental health and substance use benefits as they do physical health benefits. And it would make it easier to get in-network mental health care and eliminate barriers to access that keep people from getting the care they need when they need it. So this is a top priority of the administration. We at the Partnership Center has this as one of our 5 core key priorities. Rawle? Thank you.
So one of the things that I want to do is to make sure you really understand who Dr. Q is. So I know that there are other cities that host these kind of conferences. They don't all have an HHS senior representative who joins. The HHS fiscal budget for FY24 is $1.7 trillion. That's not Dr. Q's budget, but this is who's represented here in this panel. So you got to know that that's what you've been able to do in 8 years to bring this kind of. And so we're here to share some information, but we're also here to listen and learn as well. So as I told you guys earlier today, the foundation exists to promote the mental well-being of individuals and communities where they live, learn, work, worship, and play. We can't do it alone, but we need partners like HHS, because the reality of it is the known barriers above the line, parity, again, because we're doing this mental health campaign, Mental Health Care Works. When I say parity, some people know what I'm talking about. Most people don't. So I can't talk to you about parity. What I have to talk to you about is the prioritization of our physical health in the same way we need to prioritize our mental health. There are over 90 million Americans who are full-time employed, who have told us through research that they're willing to take the first step to care if they could just understand this system. And a lot of times when you see the signs on the road, Go east if you want primary care. Go west if you want mental health clinic.
Wow, that's so true, yeah.
So the system is set up to divide left hand and right hand when it's the whole body needs to be whole and well. So we got to make sure we're prioritizing our whole health equally. And we're about 2,500 years behind. Because for well over 2,500 years, people who have suffered from mental illness have always been shunned. Have always been shunned. And the reality of it is, we have to break that cycle. We can't disrupt the cycle. We got to break it, because if we don't, we're going to continue to get the same negative outcomes. And we're not talking about saving one life. We're talking about saving millions of lives who we're losing every day. In the youth mental health crisis, the number 2 cause of death for somebody between the ages of 10 and 25, death by suicide. 10 and 25? And what Dr. Q talks about, and she might say something, why was I born? Not what am I going to be when I grow up?
Yeah.
Right? So but some of our other barriers that we have to talk about, and again, the reason why I like to talk about the 90 million people full-time employed is because they have coverage. But what ends up happening, and again, this is under that umbrella of parity, the coverage for health insurance for primary care doesn't reimburse at the same level for mental health care. And so sometimes when we say we have difficult time finding a doctor or somebody to serve our needs, if you go to your pediatrician, there are more pediatricians than there are in the United States psychiatrists. And there are more pediatricians doing with the mental health of our young scholars, especially as school starts, than there are psychiatrists in the world. But the pediatrician getting full-time reimbursed, so they might have to explain something. The psychiatrist now has to make a decision if they get the referral. Do I take a discount, or what a lot of our members started doing a generation ago? I only do cash pay. I'm not going to do insurance. So what's the point of being covered? I got health insurance. I got a mental health problem in my house, but you're not going to take it, because you're not going to get your money back. So, and the last thing I want to say, because we're here and I'm going to turn it back, there is a spiritual barrier. I just want to be honest that for too many years and multiple generations in my own family, we were too blessed to be stressed. And if you had heard most of my same speech 10 years ago at 9 o'clock, I might have opened it by saying, I'm Mr. Rawle, I'm here, and I'm too blessed to be stressed. And what we now have realized, stress is going to be a part of our life. So you can be faith and works when it comes to our mental wellness. So yes, you can be stressed, but we got to put that together with some whole being of health.
Wow. And I want to piggyback on the barrier conversation. And when I think about, and I'm as a fellow faith leader, right? The cliches that we use to really mask, what's really going on the inside. And we even use, depending on your faith tradition, mine is, Christianity and using God's word as something to try to create that everything is okay with me, and not recognizing that it's okay not to be okay. And sometimes I'm walking down the hall and I feel like I'm broken in a million pieces. And then there's other times I feel like here I am to save the day. But I need to be honest with all parts of me, as a leader, so that transparency can translate into my congregation to allow them to be honest with who they are. But if I keep creating this Superman complex of I'm always okay, just say your prayers and everything will be fine. If I keep creating that narrative while they're suffering, they'll try to achieve something and be someone they can never be. And that honesty must start with us. It must start with us as leaders. And as I was thinking about the barriers, I said, all of our communities are different. We think about, the social determinants of health, but you got the inherited trauma, you've got vicarious trauma, you've got racism is trauma. Let me say it again, racism is trauma, period. And so, with us, and I was looking back on this, that on our 988 Lifeline website, there is helpful pages that share some of the specific challenges for addressing mental health. Let me just say in my community, they note that due to stigma, or you want to call it fear or whatever, lack of culturally competent providers, mistrust of medical providers due to historical abuse, cost or a lack of insurance, and or limited options in their area. So Black adults and youth often experience multiple barriers to care. So we don't have one barrier, there's just multiple barriers. And if I could just take a moment, and I always bring this in, and I brought this in last night, and it is to your point of what I discussed last night, is like my barrier, which was strong in my Black community, was stigma. Stigma, period. And it's real interesting when you look at our generation now, we're the ones that are suffering. Our kids are ready to come out and talk about this and have real conversations, and we're still the ones in the closet. So in my neighborhood, I grew up in New York City, in Spanish Harlem. I talk about my bacallism. I used to be able to walk down the street with my 25-cent sugar cane and enjoying, that, and slapping some garlic on my bacalajitos, if anybody knows what that is. But anyway, so in my particular household, there was so much stigma that we didn't get help for anything. It was like, my dad, he had PTSD, and I share about the fact that in our kitchen cabinet, it was more pills in that first row than there were dishes, and being sensitized to the ongoing ambulance coming in to, take care of him, and hearing the screams and the hollering throughout the night, my mother having to create a separate sleeping space, and then I'm thinking about my 3 sisters addicted to crack cocaine, never getting help, and my brother, who was addicted to heroin, and then HIV/AIDS, and in and out of prison, bad blood transfusion, he died. And then you look at the guy that's with the shopping cart down the street on 125th Street, matted hair, the things in his cart, that was my brother. He died. And when I think about my 3 sisters, on the crack cocaine, and to God be the glory, none of them on it, but one of them died, and then my other 2 are alcoholics. And so all of the things that went on in the house stayed in the house, because we live by one of the worst statements, and I say this everywhere I go: what goes on in the house stays in the house. And some of this stuff needed to come out of the house so they could get care. My 14-year-old nephew committing suicide while the 10-year-old brother watched. These were real incidents. These were my experience. This was my trauma. And to the point of Dr. Rawle, there was a time when I said to myself, why was I ever born? And I was really saying it wasn't about why, what is it I'm trying to be? It was like, why am I even here? So that was my beginning of suicidal ideations. And so for us, it's important that when we think of the barriers, that we don't take stigma, however we call it, stigma, fear, etc., lightly, because that is a real existence. It was real back then, and it continues to be real today. But we collectively can do more in this space. Thank you.
Well, thank you for that. So why should faith leaders be included in this mental health conversation? Why are they so critical?
So the message is important. The messenger might be more important, right? So Aaron could have done everything Moses was called to do. But the recognition was to turn that moment into a movement. I need somebody who can really go out. And the front porch of mental wellness in almost any community is a faith leader. And that person is going to direct, because they have not only a real Rolodex, they have a digital Rolodex, and they know everybody, right? So if they're shutting a parishioner, congregant, church member down, temple member down, they're not going to go get the help they need. Or if they're making sermons and other statements that make it feel like I have sin in me because I'm touched, or somebody in my family is touched, well, don't come around here. You're excommunicated, right? So we have to have humanity back in the pulpit.
That's so good, yeah.
And that means that faith leaders need to be supported for their own self-care, but they also need to be in a better position to support us. So like Amy described my bio, so I was a psych major in college, and I left psychology and went immediately to law. Now, it was kind of interesting in chapter 1 of my life, Dr. Q, because when you pick in juries and try to read judges, Judge Huff, having a background, I'm going to tell it like it is. Now, y'all want the truth or y'all want me to give y'all something?
Right.
You trying to read judges, and it helps to have a little bit of background in psychology, but I was running from it. And so then I went to AARP, and before the George Floyd episode, we just running, we doing our advocacy, we doing our, and some of y'all know the great work that AARP does in Bexar County. And the Spurs, baseline bombs and all that. I was the one begrudgingly who signed off on that. I'm like, oh, I don't know if I'm getting in trouble for this. But it's worked because the people we had doing it here understood the community need. And you got to let the people, let your stars be stars, right? And that's what we need faith leaders to do. When I recognize who these stars are in the constellation of my congregation, I got to let my stars be stars. And I'm gonna still get credited on that. I don't have to do everything. But in chapter 3, I started looking because I was crashing up against Medicare, Medicaid, and mental health. And then I was doing Obamacare before it was law, trying to help make it be law. And I know that's against the law down here. But the reality of it is, just tell them there's some guy from Houston, they'll be fine. They'll understand. Oh yeah, he from Houston, he don't know better. but here's what happens, Dr. Q. Here's what happens.
What happens?
You have these episodes in my own journey. Where a faith leader actually who has gotten me on the path to come back to my roots in mental health, because I was doing foreclosure defense right at the beginning of this 21st century, before they called it the foreclosure crisis. And I had a faith leader come to Mr. Rawle, I got a lady, her mortgage is upside down, but she's telling me she's paying every month, and the bill keeps going up. Now, she didn't know any lawyers who knew how to go up against these big banks and mortgage companies. It was a faith leader. So ultimately, they have these tools, they have these tips, they have these resources, but if they're closed, if they're shut down, Amy, the people who need the help, who come and say, I want to be helped, right? Here's the paradox, and some of you know this better than I do, who sits up here with John Henry syndrome. I'm admitting to you, I do. 5 weeks ago, I passed out at an elevator, and all I remember doing was hitting the down button on the elevator, leaving the vent. I hadn't eaten all day, gave all my speeches, did everything. When they brought me to, EMS had ripped open my shirt and suit. Fortunately, it didn't mess up my tie, but they had me all strapped up. And I had a significant bout of hypoglycemia. And left an event. And I think I was going downstairs to grab a Nutra bar or whatever, but we need them out there. We need Dr. Q's, we need Amy's, and we need you. And if we don't take care of ourselves, we're not going to be able to take care of anybody else.
That's right. And I just want to applaud Dr. Rawle. He's just so humble, but he's so strategic and so wise, and it's such an honor for us at HSS to work with the APA Foundation. And when you were talking about, your question regarding the, why the faith community, because we're the trusted messenger in our community. And when you think, listen, be trusted, but we don't have to be perfect. Right. We don't have to be perfect to be trusted. But they want to know that we recognize that we're not perfect. Because I think the problem is when we think of that word, trusted messenger, when we leave seminary, I'm a seminary doctor graduate, when we leave seminary, there's such an expectation on being flawless that sometimes is self-imposed. And so we have to know that when we're talking about needing the faith community to step up to the plate, we're saying that because we're trusted messengers, not because we're perfect, but we're being perfected. And if they can hear us be honest behind the podium and behind the pulpit, even incorporating that in our John 3:16 message, then perhaps we can create a greater vulnerability in their space to recognize, well, if my leader is suffering as well, if my leader is having challenges, if my leader had an anxiety attack, oh, my leader didn't get sleep, oh, my leader had felt feelings of depression and oppression, my leader says, every now and then I'm not okay, my leader can create that vulnerability beyond that was such a great message. There is so much hope we can instill, and you hear my passion because you already know that it's personal for me. But if we can instill that in our people, or we can encourage others to instill that, we can find ourselves on a road to recovery and healing like we have never seen in this nation. And so my encouragement to everyone, it's no different than what we did with HIV/AIDS. I remember when it was plaguing our neighborhood and nobody wanted to talk about it. We thought that, I'm gonna drink your water, I'm gonna get it. If I use the, restroom behind you, I'm gonna get it. But then, there came a point where we just stood up behind our podium and say, guess what? My brother, my sister, and then having someone else come up and share their testimony. And then before long, we started having people just come and talk about what they were going through. Do you know how much healing takes place through sharing lived experience? God is the perfect being. We aren't. We are merely vessels, and he wants to use us through our brokenness, through our handicaps, through our bleeding, so that we can be even more effective in taking care of our parishioners. So why faith? That's why. Because they're looking at us, and we hear the stats from, the reports, that they rather come to us first than go to a clinical setting. Even though when they come to us, we're not Superman, we don't have all the answers, that next point may be to refer them to a clinical setting. Right? So we also have to be careful in that, because we don't recognize that sometimes in that Superman complex that we put on ourselves, we can re-traumatize. And let me give you a case in point, and I'm gonna turn it back over to Amy, because I can talk about this all day. But when I was leading the work in trafficking in New York City, which was a work that I ended up needing to retreat from, because I did experience a point of burnout. And it's because I felt like I had to be on 24/7. It's like me putting my feet to the gas pedal and going nowhere because there was no gas in the car. That's the point I ended up at. But during that work, we found that during that work, we found that there were those that created this narrative of what they needed to do next. They created the narrative of, it's time to get up. It's time to do this, particularly in that faith community. And what ended up happening, they thought of people that control them as secondary pimps. And so we have to be careful in our narrative, right? We don't have a right to put an expiration date on another man's trauma.
That's right.
We don't have a right to tell them when it's time to get up. The right that we have is to be in the dirt with them until they're ready to walk. The right that we have, that's the right, to crawl with them until they're ready to walk. And everyone is going to move at different paces. So even as the faith community is stepping up to the scene here, we're stepping up in a posture of a servant, in a posture of humility, in a posture of, I too recognize that it's okay not to be okay.
Amy, before we go to resources, let's do something at this conference that's never been done before. So you got HHS here, and you got a global philanthropy. Let's go to a listening tour. So you may or may not have a question for us, but as we're going to talk about the programs that we've built and that we're going to be implementing, what would really be empowering for us is what do we need to be baking into those components so that the programs don't fall flat when we roll them out. I got a brand new campaign I just told you about. So come to the mic and tell us, what do we need to know, what's missing, and let us hear from you now, and then we'll close with telling you some of the existing resources we do have. So is there one? Whosoever will. No, we want a mic. Come on, let's, because then you can make sure you take a picture of her when she give her thing so she can say, I was on the program too. And I spoke truth to power.
Yes.
Hi, thank you so much. I'm so appreciative that you guys came to San Antonio, so thank you very, very much.
Absolutely.
My name is Jane Hevesy. I work at Methodist Healthcare Ministries, which is a large funder in South Texas. So I'm working on some strategy for 2025 to 2030 mental health. And as you said, you go left and there's primary care, and you go right, there's mental health. But how do we bring social determinants in? Because even for me, working 40 hours a week, which that's a good week, I'm too tired to do anything. I don't even have kids. I literally, how do you cook healthy? How do you exercise? And then mental health comes into that. And then people who are having more struggles with housing and food security, it seems almost insurmountable sometimes. So I'm just wondering how HHSC is looking at that component.
Give us some love. That took courage. So you had a question? Take your time. So the first question, we're going to get you some answers. How do we bring social determinants into the conversation about moving mental wellness forward? All right.
First of all, so glad I came to this conference today. I have just been taught and coached to start teaching family-to-family classes at NAMI after showing up there as a family member, after showing up in this maze of mental health, which you guys have described so eloquently this morning. When you're put in there, especially as a family member, you find that the whole system is a maze and you can't find your way around. I'm also, I host a show that we're putting together for Catholic television called Catholic Compass, and I know there's lots of priests out there in our community here in San Antonio who are looking for ways to involve a mental health component in their communities. And so I've started to sort of find myself crossing the chasm between the mental health resources that we have and the priests that are trying to find providers to bring to their communities, to bring education programs into the communities in the Catholic Church here in San Antonio. And my question is, how do we expedite that? Because there's this huge chasm. There seems to be resources and there seems to be a need. How do we cross the chasm? What can we do on a day-to-day basis to help expedite these types of services to finding ourselves? Because there are priests who are recognizing this and they're saying to me, Dusty, we need to find a way to bring this to our parish, to bring more educational resources from NAMI, to bring more providers. Perhaps there are, LMFTs or psychologists who can help here at our parishes. So.
So we got this patchwork quilt. We got to figure out how we put it together, and it's not enough to know that the quilt exists. Got to be able, when you're cold, I need to get my hands on that quilt. And what he's telling us is, right. I'm cold, I know there's a quilt, but I don't know where it is.
Yeah.
Right? One more, got a couple more people. Yeah, come on, everybody gonna get a chance, yes. Listening to her, you're giving it.
First, I'd like to thank you guys for being here. This is absolutely incredible and such an honor. My name is Dr. Heather Barton-Weston. I'm faculty at the University of the Incarnate Word, and I teach within the School of Nursing and Health Professions, and I specialize in public health. And this has been a big push within our field to tie these faith-based communities together. During COVID, we really found our resources with our faith-based communities. During that time, many of my students were in the field working with rural communities and faith-based institutions and schools to be able to get the resources that the faith-based leaders were looking for. And it was a very hard challenge for us because we couldn't cross that barrier. We speak a very different language in public health than what they do within the faith community. One of the things, though, while working over the 2 years during that time frame, and my students as well, that I noticed is that the verbiage is not recognizable within the communities. So when someone does seek help, I'm not okay. This is a really bad day. I don't want to see you. It wasn't highlighted. And we lost people. And ironically, this also happened to be at the exact same time Uvalde went down. And I was within the county community right beside that. Those messages were lost in the narrative, and one of the things we struggled with was being able to get that narrative to families who were not involved in the schools, or did not attend faith-based institutions, or did not have transportation to get to either one. And so I guess my question to you is, as somebody who is responsible for doing these outreaches and getting students and engaging, how does that message get out to those individuals who are not living within a confined area of a metroplex when we know most of our community members are out in rural communities?
Thank you. Give us some love.
I love the love. So before we get too far down the road in this resourcing, my name's Ann Holmkin. I'm the faith liaison with the city. And I want to tell you right now that we have at least 3 amazing things that are happening that specifically are working on these frustrations that you're describing. So just so you know that, and we can take that into consideration. One, since COVID began, there has been a weekly virtual gathering called At the Intersection. It's smart, it's for faith, community, and civic leaders to be smarter, working more efficiently. And look at Peter goes, he's going, amen, yes. You need to come to that. We pack it all into 30 minutes from 8 a.m. to 8:30 every Thursday morning, which is right before council meeting, so that our civic leaders are also informed, right? If you want to be on that list, you can put your email address on a slip of paper and hand it to me, or you can email me, ann.helmke at sanantonioallruntogether.gov, ann.helmke, at the intersection. 2, sacred.org. It lacks an E. SAC, and I'm telling my folks up here, RD.org, the San Antonio Community Resource Directory, put together by volunteer San Antonians so that every San Antonian and every navigator, every clinician, every son, daughter, mother, grandmother could find their own resources in this city. It's a national model. Go there, www.sacrd.org. They're out in the hall. 3, in terms of the faith community, and it came right out of Pathways to Hope, it's called NAMI, Bridges to Care. NAMI, Bridges to Care. Also online, also in the Resource Center, right? Now there are 20 cohorts across the city. 6 to 10 congregations, organizations in close geographical proximity who are meeting the needs in that close geographical proximity. Everybody who's a part of that gets 20+ hours of free mental health training. We now have over 800 of those trained ambassadors, San Antonians who are out there. We have at least 1 cohort in each of the 10 council districts. So it's in all the geography. Our goal is 10 cohorts in 10 districts, 100 cohorts, which will be almost all of our congregations.
Okay.
So you need those. Next, whatever you're doing.
Thank you, Reverend Ann. All right, so we got time for 2 more comments, and then we're going to start rapid fire answering some of these questions that we can answer. These will be summary. For those of you from the 20th century, we're going to give you the Cliff Notes answers. And we're going to follow up with the full book. So we got 2 more comments here. Please come on forward.
Thank you for being here. Two principles of support from NAMI that came up when you were speaking was, right here. We find strength in sharing experiences.
Yes.
That's an awesome one.
Yes.
And when you were speaking, the one that came up was, we reject stigma and do not tolerate discrimination. Those have been really strong ones for me. But my question is more geared at it. It sounds to me, I'm taking away is that you're making it okay to speak about faith to a lot of people that like, whoa, is NAMI faith-based? Should I go? Are they gonna try to indoctrinate me? Are all these other organizations that are going on or being spoken of? But you're opening the door, and I'm glad. So I just want to make sure that I'm not mistaken, that that's the message that we're getting with mental health. We could relate it to a higher power.
Yeah.
Wonderful, thank you.
Hi, my name is Lisa. It breaks my heart to ask you this, but since you did ask for suggestions about what faith leaders could work on, we have a lot of very compassionate people in our church, and we've had several mentally ill people. But we have one lady that is very disruptive, some of the things that she says. And we also have people that gossip about it, complain about it. It's frustrating to me because I go to church to worship. We are going to have to identify some barriers if we're going to keep people in our church and find some kind of acceptance for those barriers, not only with the mentally ill people that are disruptive, but also the people that aren't mentally ill, that don't understand the disease and don't have the patience. And so we, as churches, need help with those situations, because I'm there to worship, and it's really hard for me personally to hear all this stuff. Yeah. And I have told several people there just isn't going to be any fighting in church, just to knock it off. And it just hurts me to have to go to say that to people I love, people who are compassionate, people that need compassion. So I would appreciate, and I'm so glad y'all are here, I would appreciate maybe some food for thought on that subject.
Thank you so much. So I'm going to real quickly go through some of the resources and answer some of the questions, and Rawle will give you a wrap-up. One of the houses of worship, again, one of the things I'm focusing on, what models and practices exist that you can replicate. I want you to take my email, because I would like to share some of those models with you via email. My email is QUE, my first and last name, QUE.English@hhs.gov, QUE.English@hhs.gov. One of the things that one of the houses of worship in New York City did, he actually trained about 2,000, it's a mega church, first responders. I really encourage those that have not embarked upon mental health education, like mental health first aid, youth mental health first aid, to get your house of worship involved in that type of training. The local pieces you can do as well. When we talked about the social determinants of health and what HHS is doing in that space, we have what's called the we're fitting it into our Healthy People 2030 efforts, coordinated through CDC. And there's also work being done through the Office of Environmental Health and the Assistant Secretary for Health, which are also addressing mental health. Recent webinars we've had incorporated through DHS and FEMA that's doing more in this space. So we're talking about it more and more at HSS and in the administration. In addition, you can take a look at these three websites: cdc.gov, samhsa.gov, SAMHSA, Substance Abuse Mental Health Services Administration, I want you to specifically look for the Behavioral Health Equity Office, which has its eye on the social challenges and concerns as it relates to mental health. Write me, I can get you these resources. Real quickly, with the Partnership Center, and this is real important. When you think of trusted messengers, the way we address that stigma in our congregation, we decided to embark upon creating PSAs from different lenses: Hindu, Muslim, African American. All of these PSAs that have been created can easily be shown in your house of worship. Just 2 to 3 minutes. You can post it on your social media site. The leaders talk about their own battles, whether personally or through family members. They address the stigma. They point people to 988. We just released a Hindu PSA. We love to be able to give you that as a resource. Number 2, we created a youth mental health toolkit. On the heels of that, which is going to be released within the next 2 weeks, is a youth suicide prevention toolkit for faith and community. We also rewrote our substance use disorder toolkit. And you know, we're in 2021, we had the highest numbers of over 141,000. You know what's going on with fentanyl. That's another conversation, and opioid. And so those we have making available to you. And I think this is how you can download it, some of those toolkit. But again, if you write me, I can share with you additional resources. We also have our compassion and action guide that I would love to share with you as well. I think those are the top resources that I want to share with you right now. But please write me, and I know we're at time, and I can get additional information. If you go to our YouTube channel, we did 3 engaging conversations with youth. It was called Can You Hear Me Now? Youth Having Their Say on Mental Health and Suicide Prevention. And one of the greatest takeaways in these sessions was adults need to become greater listeners. And number 2, can you please take care of yourselves before trying to take care of me?
Thank you, Dr. Q. Real quick, for social determinants of health, what we've started doing is a couple of things, and I want to follow up with you on it. We're talking about population health now, not even public health. It's population health. And one of the things that we're starting to do is tie some of our offerings to the Sustainable Development Goals of the United Nations. I know United Nations is not the most popular organization in the state of Texas, but even in the Republic, they have 17 goals by the year 2030. And a lot of times philanthropy is looking at those 17 goals, SDGs, right? And so what we could do, disease prevention could be population health, and if we could get better mental wellness. One of the things we want to do with the campaign when it comes to the question of how we work with the maze, we are building upon an APA patients and caregivers inventory of things you can do, but we're going to have a heat map at some point, and the only way we can upload where the resources are, where the tools are, where the tips are in community is if community shares those resources with us. Now, once we get the resources, we got peer review, so we have to make sure it really is real, and you're not trying to put somebody down a rabbit hole. But the one document we're going to be talking a lot about over the next 3 years with treatability is the Psychiatric Advance Directive. Some of you know about Living Wills and some of these other things. We actually have an app already in the My Mental Health Care Crisis Plan. Go to the Psychiatric Advance Directive, so then when you call 988, or you call 911, and the prosecutor told us herself, please tell them they have a mental health condition. Now you got something in writing that is patient-informed, where they've talked about what kind of restraints they want to do. So go find that app. We call them PADs, Psychiatric Advance Directives, PADs. And then finally, what I want to say as I close, let's keep these 3 questions in mind. We will get you something beyond Cliff Notes, because this is not a one-stop transaction. I promise you, we are going to be featuring the hard and the very good work that Bexar County and San Antonio have already done. And we're going to be evangelizing that not just across the United States. When I go to the United Nations in October, I'm taking Bexar County with me. And I'm going to be talking about the kind of stuff that I learned. I'm going to be talking about the kind of things I learned when I came. So the first question is to fix this problem. As problem solvers, what can government do? And once we identify what can government do, we need to go hard at work and be relentless to make them do what they got to do. And you're doing some of that, but they can do more. We got to push them to do more.
Yes.
And when we say we need e-petitions, I'm going to come back to San Antonio and be like, I need all of y'all who came, sign the e-petition saying, I want to take the first step, Mr. Rawle, but they won't let me because government not doing what they're supposed to be doing. The second question is, what can industry do? Right? Because we know the business of America is business. And that's certainly true both in rural, suburban, and urban communities. So how do we push industry to be more accountable and more responsible for well-being? We paying for their stuff. They got to give us some back if we're going to keep paying for it. Right? And then finally, the question about personal accountability. What can my community and I do? So we got to have accountability partners among us. And that's why I love LOVE. Amy and Dr. Q, because they are accountability partners for me, even when I say, yeah, I don't know if I can do it. I'm supposed to be in 6 different places at one time. Like, you got to go. And you got to do, because you're going to learn something if you do it. And that's why we changed our format out of respect for you, because I wouldn't have gotten any of this if we didn't hear from you. So now when I go back to the United Nations or my board of directors and say we can't do it like that, I heard it directly from the people who are trying. All I want to do is get through the day and hope that tomorrow is a little bit better than yesterday. That's patient, that's caregiver, that's clinician. Again, God bless you. I know we had time.
Yeah.
But Q, give Amy and Q the last word. I've said more than enough.
No, no, this is great.
So I'm out. I'm leaving.
I just got one more thing, I promise. September 7th, we're having our national conference in Washington, D.C. It's called Connecting at the Intersection of Faith, Community, and Mental Health. It's the first one we're ever holding in Washington, D.C. at Health and Human Services. And the reason why I'm bringing it up, because I'm all into best models and practices. I'm not looking at recreating, right? So we have best models and practices here, but we are going to be featuring that specifically at this conference from models on mental health around our nations that's going to be speaking. And I know for a fact that the next time we do this, we are definitely going to have Anna at that conference. But I want you to remember this, that Rome wasn't built in a day. And how do you eat an elephant? One bite at a time. Right? And so don't feel the pressure of having to do everything at once. Start with one simple task, and that could be just getting training or creating a youth group to have open dialogue and discussion. It doesn't have to be the many, it can be the few that can grow to create the impact in your community that you need. So I just wanted to highlight September 7th. Again, send me an email, que.english@hss.gov. So amazing, so great being with my friends, Amy and Dr. Rawle. Turning it over to you.
Great.